Welcome back, everyone, from the break. We are going to start the, just before we begin the panel discussion, we're going to start with a polling question. But let me see first if we have, we're going to talk about where HIV prevention is going. And we do want to invite some new panelists as well to the roundtable discussion. So I guess we'll start with the poll. It's a two-part poll. Here are the other speakers. So in addition to the speakers who we've had present in the prep session, we have Simon Collins from HIV iBase in the United Kingdom, Sheena McCormick from the Medical Research Council in the United Kingdom, Nitya Panupak from the Institute of HIV Research and Innovation in Thailand, who wins the award for most committed since it's 1:30 in the morning for her. And then Jorge Sanchez from CITVM in Peru. So welcome back to the speakers and welcome to the new panel members. And we're going to start off with actually a question for the audience. This is a two-part question. And we're interested in knowing what you, so if you could launch the questionnaire. We're interested in knowing what role you think cabotegravir has to play, long-acting injectable cabotegravir in the future of HIV prevention, if it were available in your location. So I'm not seeing the poll come up yet, but it will come up in just a moment. And if not, maybe we'll just start with a couple of questions for the audience and then we'll come back to the poll. One of the questions that we got from the audience was about long-acting cabotegravir and the challenges with HIV testing, and if a viral load test is required on the one end of the spectrum in terms of HIV testing. How reasonable would it be to implement that kind of a test in your setting? And on the other end of the spectrum, what about just for regular PrEP? Could we, in fact, use oral testing for monitoring people in resource-limited settings? So I'd be interested in hearing what the panel has to say about the HIV testing issues with both the current and future cabotegravir option.
Susan, I'll jump in on that if I may. This is something the 083 and 084 teams have been spending a lot of time thinking about, and I think the short answer is we don't know for sure yet. That's why we're going to be looking at this question carefully in the open label extension. Obviously, viral load tests are number one, much more sensitive, but arguably also slightly less specific. So are they going to identify infections in long-acting PrEP more quickly, or are they going to send us down a very challenging pathway of too many false positives and cause a lot of consternation with patients and providers? I do wonder, and I think the CDC is considering in the US a flipped algorithm for long-acting PrEP in a draft guidance that's circulating for comment now that would start with a viral load assay and then use other tests in a confirmatory way. I do think that we need to be careful that we don't state that we know that this is the right approach. We don't know yet. We're still evaluating it. And that we don't know if finding these infections earlier will prevent resistance. We don't know if the smoldering viremia that you see early on in breakthroughs is already integrase resistant, or if that's wild type. And then it's only when you sort of break away with exponential increases in viremia that you find that integrase resistance. So lots of unknown questions. I think it's provocative. And as Linda Gale really said to us at CROI, the challenges to the field of diagnostics to make them cheap, implementable, widely available, because this is whatever issues are with cabotegravir, we're also going to see with other future long-acting PrEP agents.
Thanks so much, Rafi. Would any of the other panelists like to speak to the issue of oral testing for PrEP Is there a role for that, particularly in resource-limited settings, or is it not sensitive enough to pick up early detection? What's the general feel of the panel?
Hi, this is Jorge. I think that oral testing might be a solution for to stop the burden on the healthcare system. By the other hand, having viral load will be probably non-sustainable over time for developing countries. So I think this is really a good question to follow and do some research on this.
Great, thank you, Jorge. Any other panel members want to speak to that?
Susan, I would just add that, obviously not fully explored, but I think so important is the concept of self-testing. And I think you're alluding to that with oral testing, and there are also finger prick self-testing methodology. So can we think about whether it will be acceptable if it is a finger prick as opposed to an oral mucosa? How important is that? So I think we really need these answers very quickly, because I think the value of self-testing is going to help to just enable PrEP options broadly. So I would just say getting those answers quickly is going to be very important for the field. And then also thinking, is it that we need one strategy for somebody who's initiating or has had a bit of a break from PrEP versus somebody who's being maintained and sustained on PrEP? Maybe, again, there's a different approach vis-a-vis that. I would just say that my heart beats very, strongly when I think that we might need viral load options for initiation, because that just throws up an enormous barrier for many parts of the low and middle income parts of the world. And so really, really hoping that isn't where we have to go. But as I've said and said again, if that is needed, then I think we have to drag diagnostics into the arena and subject them to the same kind of, strategies we have with antivirals to get them cheap and effective and rolled out in the ways that we will need to make PrEP have the impact it needs to have in the world.
Great, thanks so much, Linda Gale. I did want to mention that I guess the audience was able to see the poll. Oh, did somebody else want to speak about?
I did. I just want to concur that in a setting like Malawi, where I work, viral load for routine testing in PrEP would be incredibly challenging. We have coverage issues even for the treatment program. So I could see that would be an enormous barrier to being able to effectively implement. But we need to learn more, and we'll learn more from the HPTN 083 and 084 studies.
Okay, great.
Susan, can I shout out in terms of really persuading the diagnostics to bring us cheap point of care viral load? Because what it also brings is the opportunity to really underscore the U equals U. There is nothing more, what's more enforcing and reassuring and comforting for people who are on treatment than seeing that their viral load is undetectable. And I think that's a really important message that we've seen roll out in Europe, and it's been harder for colleagues in sub-Saharan Africa without those viral load tests. So let's put the pressure on the diagnostics.
Sounds like a good plan. And I just wanted to mention that it looks like the poll did actually take place, and in case you didn't get a chance to see it, the question was, once long-acting cabotegravir is licensed and available, how many PrEP users do you think will switch to it in your setting? 44% said most people will switch. 41% said many but not most will switch. 13% said a few people will switch but not many. And that's despite having actually a question about where you're from. 31% from Africa, 15% from Asia, 21% from Europe, 26% from North America, 3% from South America. So a wide spectrum of individuals who answered the question, and it sounds like people are quite interested in long-acting injectable cabotegravir.
Can I just say, I would like to hear Simon, sort of a more community perspective, because I think most people responding are healthcare workers, and I have this feeling that the perception from the community might be a bit different. Because there we have here, if you put together most people who switch, which is 44, many but not most is 41, is the overwhelming majority, 85% saying that a sizable proportion would eventually be using cabotegravir, an injectable. So what's your impression, Simon?
So I think if you were to ask me about long-acting PrEP, then overwhelmingly the fewer doses you need to take, the more, the bigger the pool of people who will feel that PrEP is something that they could use easily and effectively. And as each formulation becomes available, then I think that having that choice will make a real big difference. So there are people who really work very well with taking a pill every day, especially if they're able to use 2-1-1 dosing. And there's other people who just doesn't fit with their lifestyle, doesn't fit with how they approach medicine or protection. And so as we go forward, having a greater choice, I think, is going to be the answer.
Great, thank you. Go ahead, Nitya.
Yeah, I just would like to add to that from the client's perspective that we recently did a small survey among transgender women who ever use oral TDF-FTC and asked if we have injectable cabotegravir, how many of you would be interested in switching to injectable cabotegravir? And it's only like 60 to 70% of people who would say that they are interested. And then I also would like to say that it's probably not only from client's perspective, but it's also from policymaker and providers' perspective as well. And we really don't know how each country will position long-acting PrEP in their national guidelines. Will all these long-acting PrEP products be offered as like multiple first-line PrEP options for client to choose from, or will it be like sequential options, second-line options of PrEP? And I think that's totally different scenario here.
Yeah. Do you have a sense of how you think that would roll out in Thailand?
It really depends on the cost and the availability of the generic product, I would say. With the cost proposed for the cabotegravir, rilpivirine, and like what we can assume it would be for cabotegravir injection alone would be the very limiting factor that I would not see it could be available as part of like first line options for people to choose from in low and middle income country soon.
Mm-hmm. Mm-hmm.
Susan, let me ask a question to Jean-Michel. Because Jean-Michel started his presentation by saying that, if I'm not mistaken, 2016, WHO had as a goal, the target was 3 million people on PrEP by 2020, and we are a third of that. Even in France, where you have you, Jean-Michel, and you have all the IPERGAY and everything, the studies ongoing, you had 32,000 people, so very few people in proportion to the number that needed to be or should be on PrEP. You think injectable PrEP or long-acting PrEP will be the game changer we need? Because I mean, the uptake's been let's forget for a moment the price, provided price is affordable to everyone.
Sure,
why are you doing so bad?
Thank you, Mauro. I think that's. I would echo what Simon was just saying, that, the more option we have, the best it would be. And, there are people that are thrilled about injections for treatment, also for prevention. So there are expectations to get more friendly PrEP regimens. We have the pills right now. We heard that we may have a monthly pill in the future, subcutaneous injection, intramuscular injection, implants. I think, this will help, like in the contraception field, to, promote PrEP to different population. So far we've failed to extend PrEP beyond MSM in France and in most parts of the world, I would say in European countries in particular. So we need to involve as well, heterosexual into PrEP, those at highest risk. And for that, these options of injectable are very attractive.
That's great. I think while we're waiting for long-acting injectable and other oral agents and other agents that may be need to be administered less frequently, we had questions about how we might increase the uptake of the existing PrEP strategies that we have, as well as retention on PrEP, particularly in resource-limited settings. But I'm wondering if you would like to, if members of the panel would like to share strategies that they think would be useful to increase uptake and persistence of PrEP.
I can start again. I think here the collaboration with NGOs is critical, and having peers helping with, adherence, explaining what PrEP is about, also promoting PrEP in the community is key. And I think we have to underline, the critical help that we may have from the community, from NGOs, and that's why also we've been, I would say, successful among gay men in Europe, in different parts of the world, because we have a strong community network among gay men. And one of the reasons we fail to involve, community from sub-Saharan Africa or in France in particular is because we don't have the same level of networking and NGOs able to reach these individuals. And I think that would be one big step. And what we've been, what we learn also with PrEP implementation in France is to have the peer counselors on site is also very helpful. So when people see the doctor or the nurse, they also see the community advisor or counselor, and that's, I think, very helpful, and for them reassuring. It's more friendly, more attractive to remain in the process of being on PrEP.
Great.
Well,
Susan, I would. Oh, sorry, Simon. After you.
Sorry, probably just advertise it. Put some TV adverts on and make sure it's on the radio and make sure profile. In the UK, we're having, doing lots of development work. Lots of it is with community groups, but there's huge sections of the population that have got no idea that PrEP even exists. And this is, and if you're in a pub with someone or you're at a cafe and you're talking about this new technology, people are incredibly excited about it. But we have to sort of do more work, I guess, in terms of making awareness, general awareness amongst women and trans people and different populations.
Great.
Yeah, so Simon, my term for that is offering hesitancy. I think we've been so anxious that the whole world would rush forward and want to use PrEP that we've offered it to no one. We've put up all these barriers where you have to have these kinds of risk profile. You need to look like this, and everybody's like, oh, that isn't who I am. I'm not going to do that. And we've made it this highly exclusive, almost untouchable thing. And, it seems to me that we need to flip that story entirely. And it is, it's a cliche term, but demand creation is the way to go. And, I think what we've seen time and time again is that the right people will self-select themselves. They will know that this would be valuable for them and they'll step up. And, they may struggle to use daily, but they'll self-identify extraordinarily well, certainly in this part of the world. And so I totally agree with you. I think we have to get out there and just share it around. The kinds of messaging we've had around vaccine uptake, if we could do that for PrEP uptake, sure. We'd be in a very different space altogether, I think, really.
Linda Gale, do you want to say something about what's really struck me about the data that's come from Cape Town has been the support people have had from relatives, friends, and how important that has been in keeping people, on PrEP, so to speak. So, because that's quite magic, I think.
Yeah, so Sheena, I think that is right. So when we do that demand creation, we make sure that the whole community hears the story, because I think what we hear from young PrEP users is, I really need my partner to know that I need my mom, I need my auntie, I need my big sister to also be on board and to be supportive, and definitely without doubt, those individuals who've had the social network to support them, that they have done better. They haven't had to hide pills. They haven't had to, do this with the kind of discretion that means that they can't actually do it. And so without doubt, I think Sheena coming with a holistic community-based approach, and I'm always inspired by Nitya's outfit, in Bangkok, of the community prep approach. I think it's, I think Simon was alluding to that. That's where, or maybe Jean-Michel, where you have the peers and the champions around to really be supportive. I think that's where people do better. And we learned that 25, 30 years ago with ARVs, right? People do better if they've got buddies helping them to stick with it. So I think this is right.
Yeah, I just also would like to make some follow-up comments on that related to how the rollout of PrEP in many countries in Asia is really based on these key population-led services, in which we really have the community themselves design the service that they would like to have, as well as be the part of the providers who co-deliver this PrEP service to the clients. And I think that is really what has worked quite wonderfully. We have seen 60 to 70% of PrEP uptake in Vietnam, in Thailand, in the Philippines, happening from these KP-led clinics and not in the hospitals, not in the public health clinics. So this may be what worries me a bit. When we talk about the injectable cabotegravir, because when we are talking about PrEP rollout, we are talking about demedicalization. We are talking about simplification and how we can simplify and demedicalize injectable cabotegravir. That's really the question that I think we will have to answer very soon.
Very good points.
Can I just someone asked something I thought very interesting, and probably Linda Gale again, who is going to start answering, is someone who's asking how can he or she convince her government to approve the Vaginal Ring, particularly to be used by female sex workers? What do you do? I mean, what arguments do you use for your government?
Yeah, so cost is king. So again, it is going to be a little bit about, how much it costs. I mean, I'm totally in agreement with Nitya and Mina here that we are driven by what is affordable. So I think that is the first important thing. Now, happily, IPM, I know, is making this available. So I'm hoping it's going to be very affordable and very available. I think we have to speak to the health system side of things as well, because I do think sort of giving somebody 3 rings that they can take away, you're not going to see this person, for perhaps a period of 3 months, that could be very attractive to health systems. Secondly, I think if we can show in the real world environment that young women are using it, and it is leading to better adherence and better use, I think that would be another way to go. But I think that we here in this region are going to have to do much more work about socializing the idea of a vaginal ring. It's quite a foreign concept. It hasn't been necessarily seen on a big scale, other than us in our echo chamber here. So I think we're going to have to do lots more work in that regard, just generally as a community.
Great.
Or for Latin America,
that I'd like to bring to the discussion also is the education of healthcare workers and GPs, for example. This is a question from Roger Tatou I have seen on the chat, and I think that's really key also for scaling PrEP in our countries is to involve GPs. And, just this week, the Ministry of Health in France allowed GP to initiate and prescribe PrEP. And that's a big step potentially. And now the burden is on us to educate and train these physicians who would like to prescribe PrEP and monitor people on PrEP. So we have also, as I think that was Tanya said, that we should deliver PrEP outside the hospital clinics if we want to really meet the targets of millions of people on PrEP in the near future.
In Latin America,
yeah.
In Latin America, for example, community-based programs, including NGOs and social media networking, will be the way to go to scale up the PrEP program. However, the biggest problem for Latin American countries are their governments. Only 9 of the 21 countries in Latin America have licensed Truvada. Among these 9 countries, only Brazil have a clear policy for implementing a PrEP program. The other 8 countries, they have licensed the drug, but it's only in the private sector way. So they can get a prescription, but they do not get from the government. Argentina and Brazil actually are moving forward to that, close to Brazil, but they are still not there. So I think the lack of commitment of the governments are key in Latin America because they stopped the rollout of the program.
I think we don't talk about Latin America. What happened? Because we don't have any social movement as we had for HIV infected people who drove the movement, drove industry and government to the present situation where people have wonderful drugs that if you take them properly, easy drugs to take, you're going to live nearly normal life. So there's no real societal pressure on government and on industry, as I think someone said about the diagnostic part of it. There's no pressure on governments to do anything about PrEP, particularly now when all of you are aware of what's happening in Brazil, the government we have, which is spilling over most of Latin America. There's a drift, it's more than a drift to the right. And so these people are going to do nothing for PrEP unless there's a movement from society, and society doesn't feel at risk as they felt, as the gay movement felt in the 80s and in the 90s, and did something, and that changed the world. So unless there's this pressure coming from society at large, I don't think the governments are going to move.
And does the price of generic PrEP help you, Mauro?
The price, if you're a middle-class person, is cheap. But for the vast majority of the population, it's not cheap.
No,
so it's about $50 a month, less than $50 a month if you take daily PrEP. So for any middle class, that's very cheap. But if you have 14 million people unemployed, and you have a minimum wage of $100 and some dollars a month, $50 is a lot of money.
Yeah.
It has to be the same price as a couple of pints of beer and a packet of condoms.
Yeah.
I just remember when we started rolling out treatment for HIV. The way to push the government in many Latin American countries was Sweden to do a suit to the government, and there are people that start winning or beating the government, and they start getting drugs from the government. At the end, this end up having a government program for HIV treatment. Maybe that also will be a way to start, so people can sue the government to start receiving PrEP, and that might be start a social movement.
I just want to add quickly here. I'm sorry, Gina.
There you go. There you go.
I just want to add briefly that to get government's commitment and endorsement of PrEP, it's probably not only about cost, but it's related to stigma around PrEP as well. I think many government is very frustrated talking about PrEP just because they feel that this is something that could harm their condom program, etc., etc. So just to make all of us aware that you may also need to address a PrEP-related stigma as well when you talk to the government.
And I was just going to say that, you know, it's a depressing theme, really, and we can't end on this depressing note. But, you know, it took us a long time to get NHS PrEP in the UK. And, you know, when the government announced it, the night before lockdown in March 2020. It was completely lost in the news. So there are also other things you can do like that. And I just say to Jorge and Mari, you must never give up. And I think that camaraderie between clinicians and NGOs, the community and voters, they do matter. Governments do listen to voters, but you have to corral them and make that pressure. So, you know, let us know what we can do to help, but don't give up.
Of course.
We did have a number of questions about 211 PrEP and whether or not, and I guess I would ask Marta, in terms of the PK and what we know, what about TAF FTC for 211 PrEP? What about using 211 PrEP in other populations other than men who have sex with men, heterosexual men, and or women? Is there any role for 211 PrEP in those settings?
So potentially, I think without the data is really difficult to answer the questions. I have to say, if there were some surprises in the PK of a drug or the relationship between the PK and PD of a drug that was in PrEP, that has been in PrEP, you know, Pivoring couldn't be used, Truvada has to be used every day in women, tough at the beginning, we didn't know what to do because of the tissue data were scary, and then we had to have the phase 3 study. So I'm sorry, I'm not really giving you an answer.
No, you are giving me the answer.
I'd love to give you an answer, but I am more hesitant than giving you an answer and trying to guess than in treatment, actually, where I would have a confidence, because I think we've learned from our mistakes in a good way because of all the development of drugs. So I think the data are really, really important. I mean, I spent months of my life trying to understand what the thresholds of concentrations for prevention was. And then at the end, we used the one for treatment because we can't figure it out until finally one day, Peter Anderson actually did a very elegant work and gave PrEP to people and started to measure it in details, which is highly, you know, complicated research. So it's really difficult to predict. And I think it is better to be safe than sorry, especially because even when we think we know what we're doing, we see breakthrough infections. We don't understand why a minority of people with perfect adherence, perfect concentrations still develop HIV. So I'm not gonna guess. I'm really sorry.
No, that's actually the best answer, is that we actually need data, and we can't necessarily extrapolate just from the PK.
But I can add something about that, if you may, Susan, is that, you know, regarding the PK, if you look in blood or within cells, with TAF FTC, it looks good. If you look in tissue, it doesn't look good at all. And that's why I think it's critical to do studies and to see whether TAF FTC is also a regimen we could use for on-demand PrEP. And so we're thinking about doing a study looking at that, challenging in terms of, you know, study design, number of people to enroll. But I think that, you know, eventually we may do that.
but also where you measure the drug and how you measure the drug. These are not standardized methods, just a very few labs do it in the world. So it's an incredibly difficult question to answer. And this is why, like you were saying, it's PK/PD, is the PD that is the key element that gives you your answer, although it's time consuming and very expensive. But unfortunately, that's where we are with PrEP indeed.
In fairness, we don't quite know the most important site of transmission. So it was a really interesting result in the Discover trial. I think that, and it did make me think that the PBMCs were more important than the tissue at that point. But what I love about IPAGAY is I feel that does give us the answer for men. The 2 pills before and the 2 days afterwards for starting and stop. And when you look at the risks of acquiring HIV across the spectrum of the different sorts of sex people have, it seems very comfortable to recommend that regimen for starting and stopping for all men. And I think we have, Simon is nodding and Jean-Michel, you're nodding. I think we are in agreement in Europe that for men, 2 pills to start and 2 days of pills to stop is fine. And then women and others, it's more difficult. So do we have to say 7 days there in, 7 days out? But we do need to provide people with simple messages to follow that allow them to cycle on and off PrEP safely, as safely as possible.
Are you 100% convinced, and that's Jean-Michel more than anyone else, that the 211 for the persons who are really, really occasional users, someone who's going to use it once a year? So that's a really, really on demand.
Again, I would say it is difficult to have, good data on this specific question. And we are trying to approach the answer by looking at, people who have more frequent sex, but still not every day. And, there is a rationale to think this is effective, but obviously that's very difficult to demonstrate. But again, we've seen very few failures, I would say, not even in people who were, adherent to the regimen, the dosing regimen we prescribed. So the failures in people taking PrEP are very rare.
I was very impressed by your presentation when you said that no one who took at least 1 pill failed. Well, the day before, the day after. That's really impressive.
Well, again, we have to be cautious with that, but I don't recall exactly how I phrased it, but clearly, if people take PrEP as recommended, it works very well. And, a couple of years ago, we've been concerned about a few reports of people, getting HIV infection despite good adherence to daily PrEP or because of multi-drug resistant viruses. And we have not seen any more reports of, breakthrough HIV infection in people using daily PrEP and infected with multi-resistant viruses recently. So that's a bit reassuring as well on the effectiveness of PrEP in the real world.
And I have a question for Rafi. Rafi, the breakthrough infections with cabotegravir, do you look at the subtypes, viral subtypes?
Yeah, we have, and just sort of guessing where the question is sort of going, there seemed to be an increased rate of failure in the cabotegravir rilpivirine therapeutic studies in the A1 subtypes, and we didn't have any A or A1 breakthroughs. So it doesn't appear to be the same issue. So, we're looking at a lot of different potential explanatory models to tie it back to these other conversations. And Marta's really important point is, cabotegravir partitions into rectal mucosa at about 8 to 10% of its plasma concentrations and about 20% in cervical vaginal tissues compared to plasma. So, particularly at onset, is there a period of vulnerability? Or are rectal or vaginal tissue levels, if they do end up being a determining factor, are they more sensitive to smaller fluctuations and concentrations? We just don't know the answer. And again, those delays in timing with regard to finding when the exposure and infection occurred make it that much more challenging to know exactly when to look at what parameter. So lots of additional investigations to be done.
If I can very quickly add one point, obviously I fully agree with the issues that we discussed around viral load for cabotegravir PrEP, especially in low and intermediate income countries. But I think that the CDC guidance is really helpful at the moment, at least. And then Rafi said, hopefully will evolve, because it might, doing viral load for breakthrough infections might actually help us understand why breakthrough infections occur. So actually, I don't think it's silly that the CDC said, let's start with viral load. It might actually give an answer from real world data sooner than designing another study.
Well, before I go into that discussion, I think I'll have to interrupt because our time is almost up. So I want to thank everyone for joining in, all of you for participating, for your talks, wonderful talks, the discussion we had. And I think we have a few slides I want to show you just to remind you about the feedback that seems extremely important. That's the only way we can improve the meeting. The only way we can do better meetings is by getting your feedback. There is a general meeting evaluation. Please fill it, respond with all honesty. If you didn't like it, say exactly what you didn't like, how to improve it. And as soon as you complete it, that's a carrot. We're going to send you a certificate of attendance. Well, the recording of this meeting will be available on this platform until June 23rd. And it's just the same credentials you use, log in today, you can use again to rewatch the presentations. And just remind you that very soon, in 3 weeks' time, there'll be the international workshop on innovations in delivering care, and the registration fee is waived for healthcare providers. And we're going to have another meeting like this one in December. It's going to be a larger meeting, a 2-day meeting, in which we hope we'll be able to discuss other things other than PrEP and vaccines, that we'll be able to discuss other interventions that we did not have time to discuss today, like male circumcision, condoms, the treatment and prevention of STIs. So thank you very much for participating and for attending. Thank you. Susan?
And I just want to add my thanks to all of the panelists, all of the speakers today, and all of the audience for participating. I'm going to remember, it sounded like one of the key take-home points was demand creation is important, and offering hesitancy is really the bane of our PrEP existence. And we need to get PrEP out there to more people in more ways using key populations. So thank you again for all of your participation, and we look forward to seeing you again at the December meeting, and before that in the other meeting that was mentioned. Thank you.